I am a full-time NHS consultant working in a hospital really very similar to this, a district general hospital in the West Midlands, whereupon I gradually became tired of treating case after case of people with sepsis and people who should really have been saved. Now I've told there's a 1 or 2 second delay on this. So the chap on the left there is Jem. And Jem was 37 when this photograph was taken, and Jem was also 37 when he died 2 weeks after this photograph was taken. The family had returned from the holiday to Jem's anxiety to a vasectomy which was to be performed in the community. And he had the vasectomy and it went uneventfully, and we don't know for certain that it was implicated in Jem's eventual demise, but it possibly had played a role in it. Jem was self-employed. He was a company director. He built exhibitions at the National Exhibition Centre near Birmingham. And so he took himself back to work the next day to ribbing from his colleagues and so forth. But he took himself back to work for the first time in Karen's memory. He came home at 4 p.m. and said, "I feel lousy." Now at this stage, nothing more could have been done. He probably had a viral illness, it was probably self-limiting, and he did what most of us would do. He went for a lie down, tried to drink plenty of fluids, took some paracetamol. Karen went on looking after Tom and Emily, and they're standing on a box there. Emily was actually 9 when this photograph was taken. But she went on looking after Tom and Emily, doing the usual parental things. She fed them, she made sure they were doing their homework, she nagged them about bedtime and so forth. So it was some hours later before Karen next saw Jem. And by this time, he was different. He was just slightly delirious. He was slightly confused. He was issuing odd responses to her questions, and at times it was like his speech was slurred. So she phoned the GP, who was performing an evening surgery, who said, "Bring him in." So she did. It took her 1 hour to get this fit, strong 37-year-old man down the stairs and into the car. Further 20 minutes to get to the GP's surgery. He was seen straight away, but Karen doesn't remember any observations being taken, certainly wasn't given any written safety netting instructions. And the GP said, as we quite often hear, this is a minor infection, take plenty of rest, take some fluids, take some paracetamol. Now that's difficult to criticise really, because Jem wasn't in an at-risk group, he was presenting with very, very common non-specific symptoms, and it's hard to criticise the GP at that consultation. Karen thought nothing more of it until the following morning, whereupon Jem was worse. He was now vomiting, he had diarrhoea, she noticed a bluish discoloration in his fingers and in his lips, and he was at times very, very difficult to rouse. She noticed his hands and his feet were cold to the touch. So Karen then phoned the GP surgery again, who this time arranged for a home visit, recognising that his symptoms sounded serious. Came to the home an hour later, again took some observations, did not take a blood pressure interestingly, but recorded a pulse, recorded a temperature, and the GP recognised that there was a possibility of a wound infection. So the GP gave this now vomiting man some oral amoxicillin and told him to get plenty of rest. Jem continued to deteriorate during the rest of that day because people have faith in doctors. The GP had seen him, the GP had examined him, and that was good enough for Karen. So she ignored Jem deteriorating for a further 10, 12 hours. By that evening though, Jem was now no longer rousable. So Karen called 999, the paramedics recognised that he was critically ill and took him to my hospital. Whereupon, in my emergency department, he had a cardiac arrest. And then we failed him too, because outside the 4Hs and 4Ts, no one thought to ask why this young fit man had suffered a cardiac arrest. And it was a further 7 hours before we thought to give him the potentially life-saving, but by then too late, antibiotics. Now that was all 13 years ago. And I was blissfully unaware of all of that story because that happened over the weekend. I was starting my ITU duties on the Monday morning. And I came in and the nurses directed me to Jem's bed space. He was in bed 4, but those of you who work in intensive care know that if someone particularly ill, we get diverted there first. There I saw the chart that every intensivist dreads. It's the chart with the blood pressure falling, the need for vasopressors, vasoactive medication going up, his blood acid levels, his acidosis worsening, and it was very clear that Jem was dying despite the best of our care. Still, that doesn't explain why I'm standing here today. I do remember, as clear as it were yesterday, the moment that this journey started for me. And it was where I said to the nurse, we need to talk to Karen. We need to get her to the interview room. So the nurse did what nurses do. She walked with Karen, comforting her, arm around her shoulder. I did what we doctors do. I'd stayed behind for my comfort blanket, the set of notes, and I was walking self-importantly 10 yards behind. And I noticed Karen's shoulders starting to heave. And it struck me right then that I was about to take this young woman into the relatives interview room to tell her that her fit, strong husband wasn't coming home, and that she was going to have to go home and tell Tom and Emily that Daddy wasn't coming home, all from a condition that she would never have heard of, from a condition that I deal with on a daily basis, did then, do now, and from a condition that, had she asked me if we'd brought him into hospital 24 hours earlier, could you have saved him, I would probably have had to say yes. So this started me thinking, we didn't know that much about sepsis then. You could argue that we don't know that much about sepsis now. So I and a few others around the world embarked upon a journey of discovery, of looking at the scale of the problem, of looking at the old definitions that were produced in 1991, looking at the more recent definitions published in 2001, and working out how we can operationally package these for a frazzled NHS workforce. So the first thing that we didn't know was how big a problem it is. This is Villa Park, the home of Aston Villa Football Club. If the animation were working, you would be able to tell that, because there'd be a whole load of people dressed in claret and blue. And it would allow me to ask you why it was an old photograph, how you could tell, and you would respond, someone in the audience would respond because it's full, and that would be true, and we'd have a little laugh. But it provides us with a useful context. Because the Holt End stand at the top there, that holds about 8,500 people, which is slightly fewer than the number of people dying of breast cancer every year in the UK. Doug Ellis stand holds about 14,500 people, which is give or take the number of people dying of bowel cancer every year in the UK. But our figures, our conservative estimates, lead us to suggest that sepsis claims around 44,000 lives every year in the UK. And I'm going to challenge our own figures in a moment, and I'll explain why. So this gives us the media strapline that sepsis claims more lives than breast cancer, bowel cancer and prostate cancer put together. But most of you here are clinical staff, and so you will quite rightly challenge that. You say, well, hang on a minute, Ron. Some of these people die because they've had breast cancer, they've had chemotherapy, they've developed neutropenic sepsis as a result. So they're dying of sepsis as a mode of death for their following complication with their underlying illness. Similarly, bowel cancer, they might be having a bowel resection, they might have a leaking anastomosis and die of sepsis as a result of that. And of course that's true. If you lined up a whole bunch of lobbyists like me in a room and asked them to say how many lives their condition claimed, the sum total would be far greater than the number of lives lost in the UK. But it's appropriate to double count, because as we all know, we have interventions in sepsis that are clinically effective, cost effective, relatively safe. I'm not trying to claim that antibiotics, for example, are always perfectly safe, but they're appropriate to deliver in all but end-of-life situations. So if someone is having palliative chemotherapy for breast cancer to get an extra few months with their family, of course it's right in the majority of cases to deliver the Sepsis 6 in order to help them on that journey. Now, where do these numbers come from? Well, this was the first set of things that we really didn't know. All we've got are these down and dirty things called hospital episode statistics. So what do we do with these? These are administrative data, and we try and interpret them and use them to answer clinical questions, which is not what they're designed for. Those of you with beady eyes or at the front will see the incidence seeming to go up by an average of about 11% a year over the 5-year period where that government question was answered. And we see that trend continuing, and that trend has been the same in North America, in Sweden, and in other countries that have some efforts to address the number of sepsis cases. But they're only head counts. So for the junior doctors and junior nurses in the notes, this is how coding works. If you write, when you assess the patient, sepsis, then no one comes back and writes triangle sepsis for diagnosis sepsis, or this is sepsis, or this is septic shock. Then even if the patient dies in our intensive care unit of multi-organ failure 3 days later, that will never be coded as sepsis. From an organisation's perspective, that means we don't get paid correctly for the patient, but from a political perspective and an influencing policy perspective, it means we undercount. And there's data from the UK and now data from North America, funded by the Centre for Disease Control, suggesting that sepsis is coded for in only about 40% of opportunities. So when clinical experts look at notes and they say, yes, this patient did have sepsis, in only 40% of cases is that case counted. So it's probably an underestimate. But then we started looking at the sepsis data in more detail. And these things, I think most clinical staff would say these are definite sepsis codes. So if someone's not lying and they've been coded as this, that is probably sepsis. How many of those were there coming into hospitals in England in 2016-17? 200,000. But we know it's undercoded. What we don't know is the true figure. So we started to look at the common four sources of infection giving rise to sepsis. If you count pneumonia, urinary tract infection, skin and soft tissue infection and intra-abdominal infection, you will capture more than 95% of incidences of sepsis. So how many admissions to hospitals in England with one of those codes were there? So these are the codes we used, not an exhaustive set, but a fairly specific set to one of those four conditions. There were 1.7 million hospital admissions in England during the last available financial year. So all we can use administrative data to show us is that the true incidence of sepsis in England or in the UK is somewhere between 200,000 cases and 1.7 million cases. They're not good. There are now some data from other countries. These are Swedish data that revise the incidence. And the more we've looked for sepsis internationally, the more we've seen the incidence figures going up and up and up. And obviously there's blips when we change definitions because we have to redefine how we capture these cases. But these Swedish data show that in Sweden they see 780 cases per 100,000 population per year. And this is from a national sepsis registry. If that were true, it would put the true number of cases of sepsis in the UK not at about 250,000, which is our current estimate, but at about 500,000 to 600,000. And the true number of deaths, because we believe the national mortality rate to be about 18%, to be somewhere significantly higher than the 44,000 we originally claimed. So we're being conservative with these figures. Bottom line, whichever way we cut it, sepsis is a huge problem. And we commissioned some work from this group, the York Health Economics Consortium. Now, we were completely independent of this process, and that was important for its credibility. But the York Health Economics Group, who are used by NICE and NHS England and so forth, estimated that we can make really serious cost savings directly to the NHS as a result of treating sepsis better. What this doesn't measure is the fiscal burden. The burden that comes around from people surviving sepsis, not being able to return to work at their previous level of function, if they can return to work at all, or, of course, dying and not contributing to the economy. So this same group estimated that the cost to the NHS of sepsis was around £2.8 billion a year, but the cost to the wider economy, because of lost productivity, was about £15.6 billion every year. So this is a condition whose scale is too big for us to ignore, and whose cost to our economy and your tax bill is too big for us to ignore. So that's a lot of stuff we don't know and a lot of surmising. What do we know? Well, there's really only one thing that pretty much every professional group around the world believes, and that's this. This is the lay version of the official definition of sepsis. The official definition, being written by doctors, just uses unnecessary fancy language, and I kind of rebel against that, so I will always use the lay version. So life-threatening condition, check. Arising when the body's response to an infection, so we know it's mediated by the immune system and other systems in the body, and it's an immune overreaction and cascade that starts to damage its organs. The old definition of sepsis didn't have that bit. So we now have a definition of sepsis as of 2016 that says sepsis is a condition in which a response to infection causes organ damage. So that's where we're at with the definition now. Everyone agrees with that. And the definition has iterated. Some of you will have seen a four-pot definition that used to start with infection over there, and then you had the SIRS criteria, and it had and that caused sepsis. If you had an organ dysfunction, you had this thing called severe sepsis, and if one of those organ dysfunctions happened to be the circulation, you had septic shock. It's simplified now. This is where we stand at the moment, as of end of 2016, early 2017. Everybody agreed that the old definition, the sepsis pot, was not very helpful, because some people in there would be really quite well. So, for example, a teenager with tonsillitis who had a temperature of 38.3 and a heart rate of 91 because they were a teenager and they're a bit precious, they would technically have had sepsis according to the old definition, and they did not need broad-spectrum antibiotics. And we were alarmed because we were starting to see care pathways coming through from hospitals treating exactly that. treating SIRS plus infection as sepsis and giving them, we saw not a hospital from this region, but we saw one PGD where all nurses were allowed to give everyone with SIRS plus infection meropenem, which was quite scary. So several groups wanted to look for the badness. That meant we had to treat. So we now only have sepsis or infection. Septic shock is a subgroup of sepsis, and it's defined as a worsening in SOFA score of 2 points. Now, who's an intensivist here? Okay, just the three of us. Keep your hand up for a moment, please. Keep your hand up if you've measured a SOFA score this year. So no one in intensive care uses this thing. It's called a sequential organ failure assessment score. It's blinking complicated. We don't use it as jobbing intensivists. Really, only academics in ivory towers use it as part of research study. It remains very relevant as the official definition. It's probably better than that we used before, but it's designed to recruit patients into studies and to define populations. It's not designed for bedside use. So what are we going to do about it? We need a screening prompt, first of all. So we need two things. We need a screening prompt and we need a treatment prompt. And we've had lots of people contributing to this. We've had new international definitions, as I've said, within the last couple of years. We've had a nice guideline within the last couple of years, and the wider academic community has been debating the pros and cons of each approach. There is no one right answer, but I think there is a practical solution. In terms of screening prompts, the International Consensus Definitions Task Force, which was a bunch of very clever people, proposed this. They looked back retrospectively at a big data set. There were 1 million patients in this data set, but most of them were from North America and from Germany. And they gave out the impression that they were performing something academics call a regression analysis, where we look back and we say, well, what's the respiratory rate that predicts a bad outcome? Is it 22, 23, 21, or 24? They didn't do that. They put in place about 40 parameters with set thresholds, like 22 there, and they tested them all out against each other. And they found that if you had 2 of these 3 things, you had a higher risk of death. So they proposed that this be used as a bedside tool. It's called QSOFA. Has anyone heard of QSOFA? Yeah, the intensivist, not surprisingly. I'm sharing it because some of you will rotate to hospitals that are using it, some of you might hear about it. It's largely discredited now. It crushed and burned within 3 months of it being proposed. And this just goes to show how fast changing a game sepsis is. So literally 3 months after QSOFA was proposed, this prospective validation found that the National Early Warning Score and the modified versions of the Early Warning Score were better than QSOFA at predicting bad outcomes in patients with infection. So this gives us, we think, for the UK, a pragmatic solution. This is News 2, which I know you're not yet using here, but it is, to use a politician's language, highly likely that you will be using News 2 here within the next 12 months. Why? Because NHS England is going to mandate it, and they're going to make it a condition of some enhanced payments that trusts get that they are using News 2. So it's highly likely you'll be using it. And News 2 is not that dissimilar to News 1. It's still produced by the Royal College of Physicians. It's better than QSOFA, and it should, if you're using News now, until we change, let's use News, that if the new aggregate News is 5 or above, we need to think sepsis. Now, that started to cause some similar care pathways coming into our door, with people very proud of them saying, well, we're just going to treat someone with a News of 5 and an infection as though they've got sepsis, and we're going to give them meropenem or we're going to give them pip-taz. We weren't very happy with that for the same reason as SIRS plus infection. You can have an aggregate News of 5 without any red score and actually not be that unwell. There probably is time in these patients to consider whether antibiotics are necessary. So we started to look at it. This is a data set we've got in the southwest. There's now about 40,000 people in. The data set is populated by people arriving in emergency departments with clinical suspicion of infection. So we said, well, does your News score predict mortality? Well, yes, it kind of does. As the News goes up, your mortality rate goes up, but that's not sufficiently discriminatory. You can't say to someone, you've only got a News of 4, your risk of death is only 1 in 5, so we can send you home. So we needed something better. And so we started to play around with stuff, but still nothing was as good as red flags. We added lactate to start with, so any triggering News score, And actually, it worked at a news of 4. It was slightly better at a news of 5, but not much. So we thought a news of 4 might be a starting point. That with a high news, as the lactate level went up at presentation, the mortality was more different. So it's starting to become more discriminatory. But what we really wanted to look at was what would happen if we treated everyone with a high news score as having sepsis versus only people with a red flag, which is one of the criteria scoring 3, and a few other bits and bobs. Well, actually, most people who trigger a news score have one parameter scoring 3. So they have one red criteria in the news chart. And they have similar mortalities if they have a red flag compared to if they don't, compared to the aggregate news score. But if they didn't have a red flag, their mortality was significantly lower. So this would be they've got 2 2s and a 1, or they've got 3 1s and a 2. You can do the maths yourself. But if they didn't have a red flag, they didn't have a parameter scoring 3, they were significantly less likely to die. What does that mean? Well, that means that just in this population of 21,000, we would have given nearly 2,000 more courses of antibiotics out than if we'd insisted on there being a red flag. Nationally, it's about 15 times that. So we'd be giving 30,000 more courses of antibiotics out if we chose to treat everyone with a high news score. So we don't recommend that that's done. NICE would shoot me if I didn't show you their list of risk factors. They're pretty obvious. We know what the risk factors are. The very young, the very old, people with risk factors that we've inflicted on them or an injury's inflicted on them. People who are immunosuppressed. And again, it depends where you draw the bar there. Do we count as immunosuppressed everyone with type 2 diabetes or taking 5 milligrams of prednisolone for polymyalgia? Or do we only count people on anti-cancer drugs? Women who are pregnant. Now that's interesting. Women who are pregnant seem to be about 50% more likely than women of a similar age who are not pregnant to develop sepsis. But they are about 1/5 as likely, if they do develop it, to die from sepsis. So although the headlines are true, and sepsis in the last triennium, not the current one, was the commonest direct cause of death in pregnancy, the numbers, thankfully, are small. And what the press don't pick up on is that 27 women died of sepsis who were pregnant in the last triennial report. But if you look at those HES data, a whole load of women aged between 18 and 29 years died of sepsis during that same 3-year period, far more than women who are pregnant. So yes, you're more likely to get it if you're pregnant. The risk factors seem to be linked to interventions, mostly obstetric interventions rather than midwifery interventions, but the women are quite protected from dying from it. So where are we at now? Well, NHS England and we, and in fact now NICE, and in fact the Royal College of Physicians, and in fact now the Royal College of Nursing agree that we recommend that staff think sepsis in a patient who either has a news of 5 or a Q-SOFA score of 2 if you must use Q-SOFA, as well as in any patient with any risk factors. So that's our population that we'd encourage people to screen for sepsis. This is not we're treating a sepsis, we're just thinking about screening. And I understand from a quick walk around on AMU and other wards that you're about to start using electronic observation, so there's obviously some opportunity to automate some of this. But what about treatment? NICE guideline, from which we derived and designed a bunch of clinical tools, I think did give us opportunity. It isn't perfect, but what it does do is allow us to use a common language between various interfaces of the healthcare system. The treatment flags can be worded in exactly the same way for a GP or a paramedic as they can for people working in a hospital. So it does give us a good opportunity. These are not intended to be a new definition of sepsis, these are a surrogate. So let's just blow this up. This is the general practice one. And I knew I was coming to work to talk in a hospital, but because the language is the same, the general practice one is very similar to the hospital one. It's just that the actions are different. So in the context of presumed infection, are any of the following true? Someone's very worried about the patient, being a health professional, albeit a relative. There's ongoing deterioration or physiology is abnormal. Now, despite what RCGP would tell you, news is not yet embedded in general practice at all, and there isn't much evidence to support the use of news in general practice, so no one can suggest that they should. So we've kept it loose there. Abnormal physiology. Someone's worried about the patient. We're going to think sepsis in the context of infection. And this is now automated within GP systems. I'll read a couple of these out because they're in very small print. This is now automated in their electronic informatics systems. So what GPs now do is they get alerts. So they'll type in a code that's compatible with infection. They'll then add in some physiology, and if there is a red flag there, the GP gets a little pop-up. Now, one of the systems, that's annoyed GPs, because one of the systems, it counts both fever and no fever as suspicion of infection. So it's causing alert prompts for sepsis in people who have no suspicion of infection whatsoever. But we're working to fix that. So we then ask, is a red flag present? And this is stuff that we're already measuring at the bedside. So these are based upon the National Early Warning Score. And we know the thresholds for the red parameters in the National Early Warning Score. For example, a heart rate of more than 130. For example, a respiratory rate of more than 25. They're counted as 3. They are based in evidence. Yes, we know people with severe COPD have high respiratory rates. People with COPD labels who go out and play 36 holes of golf don't normally have a respiratory rate of 25 when they're at rest. So we have to educate around this. These are not absolutes. They've never been designed as absolutes. For the children's one, and I think I've got a slide on that in a minute, if a 3-year-old is running around the room, tearing things apart and throwing toys all over the place, and happens to have a heart rate that's in the severe tachycardia bracket, we don't encourage GPs to send those children to hospital. We don't encourage ED physicians to pump them full of antibiotics. So we have to use common sense here. These are intended as empowering prompts. They're intended that if you as a health professional is worried, you can use these as a trigger to deliver a set of actions. But if you as a health professional who's competent to make a clinical judgment believes actually that's patient's well, then provided you put a safety net in place of a scheduled review or a handover or something of that sort, it's reasonable to document. Patient might have an infection. They do have a respiratory rate of 26, but they look remarkably well at the moment, and I don't think we need to get too excited. Please review. That's fine, absolutely fine. But it's about getting people who can make a clinical judgment to the patient in that situation. Everyone else needs empowering to pick up the phone. Now, what NICE then did is they complicated things. So we issued red flags. We designed red flag sepsis with NHS England and the colleges in 2015. NICE came along in 2016 and said, well, yes, that's fine. We'll take the Sepsis Trust red flags, but it's clearly not the case that if you've got a heart rate of 131, you're at death's door, and if you've got a heart rate of 129, you're fine and we can ignore you. So they designed some things which we called amber flags. They call them moderate to high risk criteria, but I think amber flags trips off the tongue slightly easier. And they took a slightly softer set of physiology, largely based upon the news score yellow parameters, together with some risk factors, and they said that if you've got one of those things or two of those things, we're going to think about taking some bloods if we're in hospital and getting a senior competent decision maker to make an antimicrobial prescribing decision within 3 hours. So I think that's unnecessarily complex. I think that you could, or rather the UK Sepsis Trust thinks, and its panel of clinical advisors, that you could replace that box with, there's no red flag, but I'm really worried about this patient, so I'm empowered to deliver the next action, which is call a competent decision maker to come and assess. But some trusts are using that, so it's included because you might see it. What about interventions? Well, just as with definitions, just as with screening prompts and treatment prompts, we have a basis in academic guidelines. Now, those of you that with BDIs will see that actually, with sepsis at least, we've got a lot better at being representative with our guideline panels. So yes, it is largely a group of middle-aged Caucasian men from North America and Northern Europe sitting in a stuffy room in New York City, but actually low middle income countries are now represented significantly on these guidelines. So they are getting slightly better. Now, apart from the 4 of us who knew about Q-SOFA, has anyone read these guidelines? I thought you might say that. So these are published only in the intensive care literature. There's 58 guidelines across 16 pages. And if you're a cardiologist, if you're an emergency physician, you're not going to read the intensive care literature. So unsurprisingly, they haven't been transformational. So what we did all those years ago in 2005, 2006 was simply to take out the aspects of care that a junior health professional could deliver at the bedside, package them together with stuff that audits from multi-centre audits around the country had demonstrated were done poorly, and package them together as this cheesily named thing called the Sepsis 6. So this was developed in a hospital like this by me and by a house officer and by a senior house officer and by a junior nurse, all of whom were really keen to improve the outcome to improve the process of care of sepsis. And it's iterated slightly over the years, of course it has. We no longer say give high flow oxygen, for example. But it's spread, and it works, and it's popular. and it's now in 33 countries despite us never having invested a penny in marketing its dissemination. Why? Because it's simple, because it's empowering, and because it's got a cheesy name and not an acronym. The most important thing about any tool that we produce is this. Every single clinical pathway that we have ever produced has this box. So in my organisation, if someone writes in the give IV antibiotics box, I'm not giving them yet because the patient's been vomiting and had diarrhoea for 3 days. This could just be viral gastroenteritis with dehydration. I'm going to wait until their differential white cell count comes back, for example. Then we count that as compliance with the bundle. Okay? We do not say give IV antibiotics to everyone with a red flag. We say this is red flag sepsis, this is not a formal diagnosis of sepsis, you've now got to make a decision. If there's any doubt, get on and treat. But if there is doubt, if you think it might be pancreatitis, if you think it might be the aforementioned gastroenteritis, just wait, just get some answers. Let's not give antibiotics out willy-nilly. So the tools are designed to be empowering and not absolute. When we did a Mickey Mouse study of the Sepsis 6, it wasn't quite Mickey Mouse, but it was only a prospective observational study. And we did it in a hospital like yours, and we ran it for a year, and we found 567 patients with sepsis within that year by going out and looking for them. The groups were identical. This was NIHR funded, so they had to be, otherwise we wouldn't have got the money. They had to be properly controlled. The groups were absolutely identical for gender, for age, for comorbidities, for acuity of illness, for time of presentation for hospital, and for source of infection. And the mortality rate was so much lower in the Sepsis 6 that it just seemed, well, almost too good to be true. There's very little in healthcare that achieves, if that had been an RCT and we got those figures, a number needed to treat of, let's say, 5. So we'd have to do it 5 times to save a life. But this has since been replicated in numerous studies in this country and indeed in abroad using either the Sepsis 6 itself or a very similar basic package of care. And it just seems to be the most cost-effective thing we can deliver in healthcare. I mentioned children. Again, I've just got a couple of slide shots of the pathways that we distribute, and they're really there to show that the language is identical. NICE has now given us the opportunity to use a common language for sepsis in children, in younger adults, in older adults, in adults who are pregnant, and in young people. So we've got exactly the same qualifiers. We've got similar red flags, but we recognise that children's physiology varies with age, so we've put in this table. Now this was in the NICE guideline. This is actually based in quite old paediatric. Are there any paediatricians here? No one wanting to admit to it, because they know a question's coming. But this was a paper by a chap called Goldstein, and I believe it's now about 20 years old. So it's likely that the physiological thresholds in children will iterate over time, but these are the ones that NICE recommend we use for now. And again, if you've got a 3-year-old who happens to have a respiratory rate of 41 but is tearing the place down and looking happy, please don't send them to hospital. Just think about it. So I'm just going to finish. We've gone through what I think is now a place of stability. We had international guidelines, we had international definitions, we had the NICE guideline, none of them agreed with each other. But I think what we've now got through further conversations with NICE, further conversations with NHS England, further conversations with the college, is to a place that we can operate in stability for the time being until new evidence comes along. So we screen someone we're worried about or who has a high news score, we look for a red flag, we put in place a safety net for someone we're worried about who doesn't have a red flag, and we act to deliver the Sepsis 6 with appropriate caveats for not treating sepsis mimics just to satisfy a sequin. In terms of fixing the system, what are we up to? Well, the first thing to say is these care pathways are out there, and obviously you've got your own, they're free to use. If you're working across sites in other areas, if some of you are working with the clinical commissioning group, for example, there are ones for community care centres, for GPs, for the ambulance service and so forth. And these are not intended to be prescriptive, they're just there if no one's got something that they're using at the moment. And for each of those domains, includes dental services even, we've got care pathways for children under 5, children and young people aged 5 to 12, young people and adults aged over 12, young people aged over 12 and adults and pregnant women. So they're there. We were chatting about this earlier, we're just redesigning our education programme. A lot of this was in place many years ago. We had an education programme called Survive Sepsis, which we let slip as everything else started escalating. But we've just redesigned our sepsis manual, we've just rewritten that. It's written in a very accessible, fairly casual style, and it is absolutely compliant with the NICE guideline, with the new score, and all of these other things. We do acknowledge in there there's more than one way to, whatever the phrase is, skin a rabbit, but it recommends that a pragmatic solution be adopted. And we're building other resources around that. We're doing that hand in hand with Health Education England and with the Royal College of Nursing. So by the summer, by probably the end of June, there will be podcasts and things available from Health Education England, a full suite of e-learning resources available from us, a full suite of traditional classroom-based slide sets available from us, together with the sepsis manual, and then we'll collaborate with others working in the SIM area, because that's not our area of expertise. So education is another way that we're fixing the system. Now, I'm sorry to put a picture of this man up, but I'm going to stick my head above the parapet, a long way above the parapet, and say I actually do think he takes sepsis quite seriously. And we've got another meeting with him next week, 15th, I think. And I will remind him of the phrase he issued in public, which is the same muscle and effort should be put into sepsis as for meningitis, MRSA and C. diff. He has issued words, he has put in place policy, including, for example, the sequin. The NICE guideline arose as a consequence of a ministerial mandate issued by this man, but as yet, the Department of Health and NHS England have not put their money where their mouth is. They're neither paying us nor rewarding healthcare systems to deliver better care. Some of you might challenge that, because some of you might have heard of this thing called a sequin, which stands for a Commissioning for Quality and Innovation driver. A sequin is not more money. It's money that the hospital wants back, but which rightly should have been theirs to start with. So a sequin is part of the standard tariff for a hospital. The clinical commissioning group who pays the hospital can hold a bit back and only give it to you if you jump through a few hoops. So that's how a sequin works, and that doesn't mean that hospitals are willing or indeed have ability to invest significantly. What we're talking about at the moment at ministerial level is to replace that sequin with something called a quality premium, which is extra money, which then might start to see money being thrown at this problem and investment. The other thing we're doing is going outside the UK, of course, and this other organisation that I help run, we presented a resolution on sepsis to the World Health Organization in January of last year, and we were thrilled that in May of last year they adopted it. So the WHO, in one of their resolutions, now has the statement that sepsis as a syndromic response to infection is the final common pathway to death from most infectious diseases worldwide, and it goes on to say Ebola and dengue fever and so forth. So we've got the WHO saying sepsis is what kills you if you have an infection in the majority of cases, which will start to make governments to take it seriously. And WHO has also asked all member states to report that, so that's 194 countries, to report that to the WHO Director General with a national action plan on sepsis by May of 2020. Now, we in England are sitting pretty. We're on our second national action plan already, so we've ticked that box. All 194 countries will not do this, let's be honest about that. Probably about 30 or 40 will if we look at the history of other resolutions, but at least it's 30 more countries than would have done starting to think about sepsis. And we will heighten public awareness, and we will make little apology for this. We've recently had a not huge but fairly significant campaign in the West Midlands. We're only a small charity, we can't throw millions at public awareness. We've used things like this. All the ambulances in the West Midlands are now starting to carry this messaging. The whole fleet will carry the messaging within 12 months. Other fleets are coming on board. There's 20,000 out of hours doctors' cars running around England. We might as well have those as well. Anything that we can advertise on for free, we will take. And that includes this highly researched, highly acclaimed BBC medical documentary called Holby City. It's all absolute truth. Surgeons rule the roost in Holby City. Surgeons tell the anaesthetist, for example, when to give more fluid or when to give some drugs. But Holby City is watched by 5.1 million viewers every week. And for a cost of a couple of phone calls and a couple of posters and some postage, we had 27 consecutive episodes for a median screen time of 14 seconds in main scenes behind main characters, subliminally encouraging our public to just ask, could it be sepsis? If you support the UK Sepsis Trust, which is a charity and always needs help, that's the sort of value for money you get. I mentioned the campaign in Birmingham. What we did is we spoke to the City Council and said, well, you've got buildings, can we borrow them? So for a week we illuminated buildings. This is our library, which is a bit of a bizarre building, but is fairly famous locally. We spoke to our friends JC&Co and Signature Outdoor, and they gave us all the unsold advertising space in the city on these big screens. We illuminated the town hall, we had events, we illuminated the big LED screens over the main arteries into and out of the city. Why am I showing you this? Well, yes, of course, to demonstrate that we deliver excellent value for money at the UK Sepsis Trust, but also to show that this fear, particularly of emergency physicians and GPs, slightly less so of acute physicians, that if we tell the public about this big condition that is a big killer, they're going to flood us with the worried well. We interviewed, 1 week following this campaign, 30 ED consultants, we interviewed 50 GPs, and all of them were supportive, and all but a handful of them had not noticed a huge spike in numbers. The handful that did said yes, there was an increase in numbers of the worried well presenting with infection, but it didn't cause a significant burden on the system. We were able to cope with our patients. So we're going to be doing that city by city. We're going to be collecting evidence, and then we're then going to be demonstrating to anyone who wants to hear that you can raise sepsis awareness without overburdening our system, and that's hugely important to us. We're going to be working with corporate partners to get this message out there. We're going to be working with Transport for London and probably Transport for some other places as well. We're going to be working with the Premier League. There's some activity in the last game of the season at a few matches. We're going to accelerate that into matches during next year. And we're going to be working with the Jockey Club, and we've just come from the Grand National, where for the price of a few people on the ground, a little bit of design work, we had free advertising to 150,000 people on the ground and a global viewing figure of well over 16 million people. The bottom line is, in order to fix the system, we have to do a lot. We have to change policy to help you to deliver your clinical work. We have to provide the right tools for you to tweak locally, which is absolutely appropriate, of course, to allow that work to be done robustly. And we have to get the public to be presenting to hospital on time, so that if we are a Karen looking after a gem, we are empowered to just ask, could it be sepsis, earlier than we otherwise might have done? And we'd suggest that if we achieve that, then however small a part of a cog in this system we are, we will collectively be saving around 14,000 more lives a year.